The ability to get yourself from A to B after an amputation is imperative to be able to function as independently as possible, especially when considering some of the environments patients may be living in. The types of transfers achievable with a patient will depend upon many factors and should be considered in each case. For example, the number and levels of amputations, patient's environment, levels of fitness, family support, equipment availability, wound healing, and other injuries. The skill of the therapist is to problem solve each transfer with the patient. In this practical, we are going to focus on some ideas of how to teach and facilitate safe and effective transfers as part of rehabilitation and independence. Remember, transfers may change depending on many factors, and therefore teaching patients various methods and without equipment is ideal. Consider with all transfers using the backward chaining principle as often taught within rehab for on and off the floor. Before any transfers, all health and safety aspects should be considered. For example, staff involvement, patient competence, and wheelchair breaks. It is important to remind your patient of the phantom limb sensation so that they don't try to put weight on the limb they have lost. The language used for this will depend on the individual patient. Most single lower limb amputees would prefer to transfer to their non-affected side due to the fear and uncertainty of movement in the other direction. However, most fit and well single amputees will quickly master bed-to-chair transfers. Bilateral lower limb amputees. The easiest way for a bilateral lower limb amputee to initially learn transfers is forwards and backwards. This is due to the fact that part of their body is always in contact with a firm surface, providing them with confidence, and that there are no spaces down which they can fall. It also prevents the limbs being dependent at any time. This transfer can be completed both independently and dependently as demonstrated. Prior preparation and good communication is the key with all transfers. The same technique can be used when transferring onto a Western-style toilet. If the patient will need to use a toilet or shower which is on the floor, use the bed-to-floor methods which follow. For single transtibial or transfemoral patients, use an intact lower limb and both upper limbs to lower safely to the floor and to return. Don't forget to use the knee if it's still present on the amputated side. For bilateral amputees, lower from the prone position. As they lower themselves, ensure you are there to guide their lower limbs, as although coming down backwards is much safer, they cannot necessarily see their limbs as they lower, which can make them fearful. If a bilateral amputee does have a knee, ensure you use it. Equally, remember, if the skin is intact and healed, then a through knee amputee can also weight bear distally. If you do treat a triple amputee, again ensure you use the leverage available in the upper limb.